Yeah, medicine is in aviation. They don't ask how smart you are or how motivated you are. They ask how many hours you have. How many flights have you taken in such and such weather, in this type of airplane, et cetera, et cetera. And the same thing is true in medicine. Unless you have the reps and the experience, you're not going to have seen enough to do that pattern recognition. I mean, AI may shift it a little bit.
That's a good point. But I think now maybe AI will improve. Even now, when I feed AI, because I use it to make sure I'm not missing anything, or if I can take advantage of technology that I might not be aware of. If you feed AI those little hints that an experienced eye can get rather than a green person, AI will translate things differently.
Welcome to the Precision Medicine Made Simple podcast, where we simplify the complex world of precision medicine. We're here to explore how personalized healthcare can empower you to understand and improve your health to live a longer and healthier life. Join us as we break down the latest in medical science into actionable insights. Let's make precision medicine accessible and actionable for everyone. This episode is sponsored by Biography Health, where DNA-powered healthcare is designed just for you. Biography Health is a HIPAA-compliant precision medicine platform that equips providers with AI-driven recommendations powered by your genetics, health history, and clinical insights, all while keeping data private, secure, and independent from large EHR systems. If you're a provider ready to bring precision medicine into your practice, visit biographyhealth.com to learn more. Or if you're a patient who wants your doctor to explore this, point them our way. We'll help them bring personalized healthcare to life. As a reminder, this episode is for educational purposes only. This episode is in no way a replacement for professional health advice. Please consult with your professional primary care provider for medical advice. If at any point you feel that a topic discussed on our podcast was misrepresented, or if you have additional insights that could enhance our discussions, we wholeheartedly encourage you to reach out to us. Your feedback is invaluable in helping us improve and in ensuring our content remains both informative and reflective of the latest developments in precision medicine.
Hey everyone, welcome to the Precision Medicine Made Simple podcast. I'm Taylor Koo, joined with my co-host here, Dr. William Stanford. If you heard one of our most recent episodes, we had our guest co-founder, Dr. Janice Brayman from Ascending Medicine, who is raising the bar for concierge care in Los Angeles. But today, we're with the internal medicine backbone of that team. Board certified and trained in high acuity settings, she now applies that rigor to patients who don't fit in 15-minute visits. People with multi-system, often unsolved conditions. In this practice, she leads complex case management across autoimmune disease, chronic pain, inflammatory and mental health overlap, integrating evidence-based diagnostics with targeted modalities like lymphatic and myofascial work, acupuncture, and even genomics, whole genome sequencing, and HLA typing, when the data can change care. So her aim, catch patterns early, personalized treatment, and help patients reclaim health before disease becomes destiny. Please give a warm welcome to Dr. Hengameh Monsef.
Thank you.
Hengameh.
Thank you for that warm introduction.
Of course. Our pleasure. And so starting out with, I will say your backgrounds and your origin story is a little unique. And by little, I mean very unique. And would love to hear the story of how, is it Tehran? Is that how?
Tehran, capital of Iran, yes.
The capital of Iran. So, because you migrated from there to the U.S., we don't have to go fully into the details of from the start to the finish, but I was wondering if there was any specific moments that was driving you towards medicine while you were over there and why you decided to get into medicine.
I've always been very curious about sciences. Since I was a kid. I was the curious kid that to prepare a chicken, I was the one who looked inside the chickens and if there was a heart and liver in there, and I was using my knife to dissect.
Oh, that's cool.
And she used that to get me to clean and prepare the chicken ahead of time. At some point I realized my mom is like, hey, you're making me work. That's not for science. I'm not interested anymore. But I've always been interested in science. My mom was diagnosed with kidney cancer, renal cell carcinoma, when she was 29. I was about 7 years old. I walked in and she was rolling in pain. And I never forget that. I think probably subconsciously maybe that made me even more interested to find out cures, what causes things, what causes pain, or psychological the relations between cancer diagnosis, why someone's pain is more than another person, and so forth. So that, I think that was a turning point for me.
Wow. And was there a specific role model then that you can look up to that was sort of like guiding you towards this path of medicine? And were you still also at that time?
I finished high school there, and then after high school, I spent some time in Austria before transition to United States as an immigrant. In fact, the main driver was me. We have physicians in the family, but my mom didn't want me to be a physician. Ooh. She always said, it's too tough for a woman. Mm-hmm. You're going to be a mom. You're going to take care of a family. And you have to dedicate your life to medicine, because she saw her brother, and there was a physician and so forth, how dedicated they were to their work. So I actually went against my mom's wishes. Wow. Usually the parents saying, go to medicine, do this, do that. And she wanted me to do something relaxed so I can enjoy.
Did your uncle influence you?
I don't think so. I thought he was always cool, but I didn't think of it as a career. I think it developed in time. Yes.
What's kind of fascinating is because, you mentioned curiosity. Curiosity has definitely been a theme for folks that have gone down this way of personalized precision medicine. Mm-hmm. And usually when there is curiosity, there's always that pushback. So I think it's pretty fascinating that, your mom didn't want you to do that. And
it made me want more.
Yeah, it made you want to do that more. And so as you started to go down, you wanted to go down this path, then was there an instance within, I guess, like the traditional healthcare system that even pushed the curiosity more to then going down this path that like ultimately leading to working with Dr. Freeman?
I think when I started college here and I kind of knew that I'm going to do medicine, I was introduced to osteopathic medicine through one of my family members, my cousin, who was my best friend. And I loved the idea of it. And the reason I liked it was they kept saying, you look at the person as a whole and you look at alternatives, what do you call it, alternatives, to help your body heal yourself. It never said you can do it all, but it says use this XYZ and not just push medicine. To me, that was what got me interested in being a DO. And I pursued it. And I'm still, back then there was a lot of, they thought that DOs don't know as much medicine as MDs. And now as years go by, and now I've been in practice for over 20 years, physicians, scientific communities have realized that actually the things that we were talking about 20, 30, 40 years ago actually do matter. And I'm talking about what you mentioned, myofascial release, fascia, maybe acupuncture. We don't do acupuncture, but lymphatic drainage. Now more and more surgical community using it after surgical procedures to allow body get rid of the waste products and so forth. So there's more and more data, and I think the more data we have, it's going to direct medicine to maybe a different route that are currently being taught in traditional medical schools.
Yeah, well, and with all that data, then was that also one of the, I guess, intentional factors of starting ascending medicine then, like to more of a data-driven approach where you have more flexibility as to
my transition to ascending medicine was mainly, unfortunately, was after realizing or practicing for 20 years of realizing that when you work in big organizations, I was a hospitalist. I worked and took care of really sick patients. Profit sometimes comes before patient. They want you to get the patient in. They want the patient get the patient out. And that curiosity, finding what the root cause, the problem is, that goes out the door because you basically are stabilizing them, sending them out, and it's somebody else's problem to take care of things. And that was not me. So that was when I chose to actually jump ship and work with Janice to do and practice medicine the way we wanted to practice medicine, prevent things before they happen, find the root cause of things, rather than just pushing medicine without caring why things are happening.
Yeah, I do have a somewhat personal question,
Sure.
because like when it comes to, I mean, y'all are superstars when it comes to like taking care of patients. And on your site it says patients first 24/7. Where do y'all have the time to be able to personalize all of this just for your specific patient panel, and then also live a life and have boundaries of spending time with families and your kids?
It's a good question. And I think the question is, what is your ultimate goal and what do you mean by boundaries, and how, because someone else's boundary might be different than your boundary, right?
Right.
So my balance and how I manage my family might be different than somebody else. As a physician, as I said, when you become a physician, just that career is dedication. So I feel I'm dedicated to the patient, so it makes it even harder to balance family. I guess that's what my mom said, don't be a doctor. Because it's hard when a patient has an emergency and then your daughter or your son has an issue or a graduation. Which one do you pick? It's a very tough decision. I think the way to do it and why concierge medicine is growing is by just the fact that you're concierge, you tend to keep lower numbers. By lower numbers, you decrease the number of emergencies that could happen in a day. Sometimes it doesn't, but that's one reason that patients like concierge medicine more is yes, access. But the doctor gets to spend more time with the patient and so forth. So one, you keep your patients lower, right? That's why you have to charge a certain amount of fee to survive, because you have to run it as a business in some aspects. And then you do have to set some boundaries because when you're a concierge and 24/7, the patients feel that they can text at 9 o'clock, 10 o'clock, midnight, 2 o'clock. An assistant texts you at 3 a.m. for something that's not an emergency. So we've put some messages like that you still get the text, but it's like, hey, by the way, if it's emergency, call me. But if it's a text, can it be today? Or if it's something non-urgent, can we discuss it tomorrow? And technology is your best friend here, because you don't have to put the phone on complete silence. I still can get the phone calls, but I can limit.
Right.
So there are things we can do, but it for me at least, it's an active work of balancing and reminding myself that I'm not all work. I have to do certain things to do self-care so I can take care of the patients.
Would you recommend somebody to start their own concierge practice then? Like, because in my mind, and how I'm thinking about this as a patient, concierge, I actually just learned the term concierge practice. And growing up, my whole relationship with my providers, it's changed over the years just because they're leaving different healthcare systems. And so, like, I've never had that tradition.
My personal experience is this, but my opinion is if you're graduating early, it's not a good idea to do concierge medicine, because you have to put some experience. That learning that comes with experience, seeing numerous patients will give you knowledge, wisdom, and ability to add information from, all these patients that you've received and apply. Now, if you just think about, if you're thinking specifically business-wise, like, I'm going to make more money, not necessarily, because if you're not a good doctor, then the patients might come to you, but then you lose them when you can't deliver. So probably you need to have a bit of a background and basically pay your dues before you turn concierge.
Yeah, maybe get a look at the sick care system. So, when you pivot out of that,
You've seen the worst.
You've got a fund of knowledge. You know what you don't want to do. Honestly, you don't want to be in a situation where you're reactive and not getting at root causes.
Right? Because just remember when you left residency and then 10 years after that, regardless of how much you read, the number of patients and the situations that you had to make decisions and say, all right, I'm going to do this.
Yeah, medicine is an aviation. They don't ask how smart you are or how motivated you are. They ask how many hours you have. How many flights have you taken in such and such weather and, in this type of airplane, et cetera, et cetera. And the same thing is true in medicine. Unless you have the reps and the experience, you're not going to have seen enough to do that pattern recognition. I mean, AI may shift it a little bit, but
that's a good point.
Yeah.
That's a good point. But I think now maybe AI will improve. Even now, when I feed AI, because I use it to make sure I'm not missing anything, or if I can take advantage of technology that I might not be aware of, if you feed AI those little hints that an experienced eye can get rather than a green person, AI will translate things differently.
Absolutely. I mean, I think for all of it, it's all in how you do the prompt, and the more experience you have, the better prompts you're going to do, and you're going to be able to interpret what it's spitting back to you and what you need to dig deeper into. But it's a great tool.
Do you use open evidence?
I do. I actually have it on my phone. I use ChatGPT. I do open evidence, and there are other ones and that they're coming, I think. So looking forward to them. Maybe I won't have a job in 10 years.
We're
going to have a job.
I think you guys are most definitely going to have a job because, I think even with AI, and we've talked about this in previous podcasts, but there's no humanity when it comes to AI. There's like the level of service that you and Dr. Freeman provide. I mean, I've seen y'all in meetings and then a patient calls and it could be an emergency. Like that level of care, like you can sense the passion with your patients.
At least for now, it's not there, and at least for now, it can't pick up those little details that a human or a physician can pick up on.
Yeah.
I think one of the things that AI doesn't really take into consideration unless you prompt it is, what is the patient willing to do? What can they do? I mean, you can, recommend a statin. Well, they don't want a statin, or you can recommend a particular exercise regimen. There's no time in their day they can't afford this, et cetera. There's so many factors to consider that still that getting to know the patient is.
Yeah. For example, there's some cultures, as Dr. Stanford mentioned, they don't like any medicines, right? So that art of, I do actually have a patient in my panel that when she came to me, she only wanted to use Chinese herbs. She said no to every single thing I said. So I said, all right, I need to step back. And that's what the AI doesn't do. How do you have a patient have her or his autonomy and then introduce science and cleverly, slowly bring them up to in the middle, to meet in the middle somewhere, right? So they can have certain herbs that are safe for them to have, but then use science and say, here, this is science, this is what's showing, and your herbs have not worked, maybe we can try. And I've been successful.
Now, would you say that this is pretty much holistic medicine then, like bringing into the patient like their preferences? Would you define that as the holistic approach for a patient?
It's definitely the personalized part of it. So personalized precision medicine, you have to understand the patient. That's the personalization part with the whole genome sequencing, their particular variants, their biochemistry, their life exposures. But you definitely need that part before you bring the precision medicine piece of it in, because you have to know what are they going to be willing to do.
I agree. I mean, it is holistic in a way of you are basically doing psychology. You have to know medicine. You have to know alternative, which is, I think it's the wrong word to use. I think you should be additional rather than alternative, because medicine evolves. There was a day that hand washing was, right? They laughed at you. The person is like, just a simple hand washing, right? So if someone believes in something, and if we still don't have the data, it doesn't mean it doesn't exist. It means that we might need a few years to get there, right? So the same thing as acupuncture for pain control used to be the last thing that people use. Now we used to do narcotics, right? Give narcotics, give pain medications. And now you're saying, do massage, do acupuncture, do this. If you can't control your pain, then do medicine. So I think that's part of holistic medicine, of looking at the patient as a whole and see what works for them personally.
Right. One of the common objections that I've heard when it comes to talking about just figuring out what works best for people is they don't want to hear that just have a great diet, sleep well, and then eat right, and I said diet, but and exercise then, right? So how different do some of these recommendations get? Like how personalized can they be? Because I mean, coming from a patient standpoint, I would hate to pay just a ton of money just to learn the same things
over and over again, right?
Over and over again.
Well, that's where I ask for my friend's help here, Dr. Stanford, because I'd like to, let's say you can have a map, right? This map tells you, I'm just giving an example. The map tells you need to go to this location, right? But the details of how to get there sooner before you hit traffic, or the details matter. And the details, a lot of them come in genetic form, socioeconomic factors that we don't necessarily think about. And if you know someone's genetics and HLA typing and those things that affect their immune system, or maybe cause obesity, or maybe cause inflammation or asthma, will change my recommendation. And for example, there are people that do better with eating carbohydrate and their metabolism is different. And some people do better with the ketogenic diet. Now, I understand the terms, again, why Instagram and all these social media popping with functional medicine. The problem, there are a lot of advantages, right? They're pushing doctors to think beyond the box. But one problem with those sites it makes people think that this recommendation is good for everyone.
Right.
Which is dangerous.
That's what's wrong with the current paradigm.
Yes. Yes.
We're talking to a physician yesterday talking about not just ketogenic diet or, anaerobic versus strength training.
What sort of exercise works?
But also what injuries are you more susceptible to? And then what can you build around that? And, and also measuring things like VO2 or your
heart rate variabilities
Yeah.
and all those things.
yeah, all that data is going to come in, and really that allows you to personalize and have precision medicine targets for your therapies and whatnot.
Yeah. So, for example, yoga. Everyone say do yoga, do meditation. Yes, yoga is great. What if you're hyper mobile? Then that's not an answer for you. It actually can harm yourself depending on the type of muscle you have, or ligaments, or collagen disorder, or certain things. So I think you need to have a blueprint. If you have a blueprint, your route is a lot more clear, and that's when you get personalized medicine. Because it takes guessing out of the equation, right? You're not guessing, you're not giving a standardized
One size fits
all sort of recommendation.
So now I have a question actually for the next three topics when we're going to be talking about lymphatic drainage. Question even before we dive into that. Why these three topics to talk through within this? Is this like a reoccurring question that's come up from
A
patients?
lot of patients actually ask, and these are the subjects that are not taught in traditional medical school. We learn it at DO school. So after the didactics are done, the same as MDs, then DOs take extra classes, sometimes 3 times a week, 5 to 8 p.m. You go over anatomy, lymphatic drainage, you go or fascia, which is covered all your body, is covering our body everywhere. And lymphatic drainage that basically is in around every organ. So we learn how to make it, if patients have sluggish, let's say, lymphatic drainage, which it can come with age, it can come with inflammation, it can be because you're not active or not mobile enough, or for any other reason, how to help your own body heal itself. It doesn't say it will heal you, it will say it helps with medications and other things, or activity or exercise, how to engage the rest of your body to heal itself.
Do you actually perform some of those manipulations?
I do. Unfortunately, I didn't go specifically to OMT or osteopathic manipulation, but yes, sometimes Janice comes to me and says, okay, my husband or family and relatives, or if patient come in, I do perform them.
Or you do sometimes refer them for some of this therapy, these modalities you're talking about. Are there people out there that are experts in that?
Yes. We don't have enough of them. I think in the next few years they're gonna come. It's gonna start blossoming because more people are asking for them. But yes, so I'm really big on physical therapy. They call it here functional physical therapy. There's some, Perrin is one of the DOs that came up with manipulation techniques, myofascial release, lymphatic drainage, and so forth. So there are techniques that some chiropractors follow, some physical therapists follow, that some PTs don't. So I do emphasize on physical therapy,
but they're specially trained.
There are
physical therapists.
Yeah, and there's some DOs that only practice what we call OMT. So I'm not trained like that. I didn't take the fellowship for manipulation. I learned what I learned at school, but I didn't necessarily get extra fellowship. But yes, there are definitely people that exclusively do manipulation. I was too curious. For me, it wasn't, I wanted everything.
So you mentioned, well, even though this doesn't actually have to deal with physical therapy, the physical side was what piqued my mind. Was you mentioned with steps, like walking, and 7,000 steps is it decrease depression then?
Yes, there's studies that actually now they're saying it lowers the depression. Yes, I don't think it's not necessarily the act of 7,000. That 7,000 is not a magic number. Could it be 5,000? Could it be 10,000? Probably. The more you do it, it's better. I think the way to look at it is, again, holistically, is what do you do when you walk? It's a change of habit. If you every day you walk a certain amount, now you're exposed to light. Light helps circadian rhythm, helps with depression. It produces certain endorphins or neuroprotective chemicals in your brain. It's you have time to think, you have time, mind, body. There's a lot of other aspects of, I think that's an observation that helps with depression. But why does it help depression? Because it involves so many different things. You might decide to go for a walk with a friend. You're socializing. Maybe you want to take your dog. That, again, it produces endorphins. So that's why I think that study came out.
Is there a link then with like getting more oxygen as you're walking then? Because I mean, I was looking at like the second question that we were going to talk about was like asthma then, and the link with depression then. Like, I mean, asthma, well, I mean, I don't have asthma, and I could totally be wrong in this, but I mean, it seems like you're not really getting that much air or oxygen.
Well,
then.
I think that, we all know that sitting is the new smoking, right? I mean, if you actually put a pulse oximeter on yourself when you're sitting, it's like 5 points less than if you're standing, hence the standing desk, or if you're moving. So the only thing better than standing is standing and moving. You oxygenate better. That's going to help with things like neurodegenerative disease and inflammatory conditions and all that.
Yeah, I think, as Dr. Stanford mentioned, is when you're seated, right? It's not just the oxygen. Why your oxygen is low. Your muscles in your brain need less. Your posture is different. You basically lower the volume of your lung expansion when you're seated. So and then your diaphragm doesn't open as much compared to when you're standing and walking. So there's so many different things that it's not just an oxygen. Oxygen, easy way to measure. But when you look at it as a whole, there's so many different mechanisms of standing and walking that uses your different, your blood vessels and veins in the lower extremity. They don't have strong muscles. They only return the blood up just by contraction of the muscles of the gastrocnemius muscle, the muscle of the calf. So that itself, it's just circulation. You got better circulation than your lymph nodes. So it's a cascade of things. It's never one thing.
And then stabilizing the blood sugar, that's very important. And that again, and from a holistic standpoint, these things like I call it lifestyle interventions, if you want, in terms of movement, sleep and all the rest, it affects all different kinds of chronic diseases. So it's really these things that Dr. Monsef is mentioning. When you do those things, it really lifts all boats from the standpoint of it attacks or delays or prevents all kinds of progression of all kinds of chronic diseases.
Now, something that both of you mentioned, though, is like some of this isn't going to work for everybody, but not necessarily the sum part of it. It's like some might need a little bit more, some might need to be a little bit less. And now this goes into why people should be doing whole genome sequencing then? Is that where like you get your genetic, you do whole genome sequencing and you get
the gene variants, find out where there needs to be emphasis, and then you do these things that target reducing the risk that you've identified with the whole genome.
Certain things you remember, we share a lot of our genes as a whole, like humans, right? So a lot of our genes are common. So walking is good for everyone. That's something that you don't necessarily...
It's indisputable.
It's indisputable, right? But the things that are that need personalizing is, let's say with chronic conditions, if somebody has asthma, this asthma is treated differently because some could be allergic asthma. We call it eosinophilic asthma. This one could be aspirin induced, or it could be different pathways. So what Dr. Stanford is referring to is, this is, you see a condition, right? What is the pathway and how do we stop that pathway to move forward so to avoid severity of disease or prevent it altogether? And those are the differences. But certain recommendations, as you say, you hear it over and over and over again because we do share a lot of genes amongst different races, different people. You can't avoid them, indisputable. But one is shorter, one's taller, the muscles are different, the immune system is different, the exposure to viruses or bacteria are different. I came from Middle East, so my exposure to bacteria or viruses might be different, right? So they sometimes say people that get multiple sclerosis tend to come from certain communities versus Jews get certain diseases, right? So what it shows you that our genes dictate certain differences. However, we still have common genes that we can avoid.
A lot of the drivers behind these common chronic diseases are common across ethnicities. It's like Dr. Monsef said.
So with acupuncture, then, does it work specifically better for like other populations versus others? I guess.
Well, that's a good question. Yeah. I'm not an expert in acupuncture. That's an Eastern medicine. Okay. They do herbs and acupuncture. And I wonder, HLA typing. What is HLA typing? HLA is like a name tag. Each cell has a different name tag, that my HLA is different than Dr. Stanford and you. Now, maybe acupuncture works better on people that have certain pain threshold, or they're suffering from certain different diseases. But I don't know enough about acupuncture, but generally it should work for most people unless they have really severe hypersensitivity to pain. And if you put needles, it actually might worsen their symptoms.
And there is science behind acupuncture. There's a physiologic basis for it. Without getting into the weeds too much.
So how do y'all screen for over at Ascending Medicine for like mental health issues then?
So there are general questions you ask about mental questions for depression that you have to ask. But sometimes people don't realize they're even depressed. You can ask indirectly, when was the last time, let's say if someone comes in and they're happy and they're thriving and there are no issues, you still can ask certain screening questions that every doctor asks. But if you notice, or if you have a hint of someone is not doing quite well or something is off, you don't have to ask them, do you feel depressed? You can ask them, when was the last time you enjoyed listening to music? When was the last time you went on a trip? Or you socialized, or how often do you see your friends? These are little questions that are very friendly. And you might be able to gather information that patient doesn't even realize that, oh, I might be depressed. And that's how you screen them.
So some people have said that sometimes there is something internally wrong then that could make them more, I guess, predisposed to depression. Is there genetic links to anxiety and depression then?
Yes.
Oh, yeah.
Of course. You're an expert, but there are genetic changes that in our body that not only affect our neurons, affect neurotransmitter production, neurotransmitter uptakes, or metabolism. There's so many different layers. COMT mutations, MTHFR mutations.
Some serotonin transporter type stuff that are fairly common variants that, yeah, you want to understand all that about the person because that speaks to what the target might be.
And then when you have whole genome sequencing, if you give it as a whole genome sequencing, these things might not be picked up. However, a clinician that will write, we call it phenotypic signs and symptoms. When you put that together, and let's say a patient is exhibiting signs of depression, you put that in a corner and say, look into this deeper, then you can look and say, hey, I want my geneticist to look deeper into that HLA types that.
Yeah, it's clinical correlation is the
key
term. Yeah.
So basically, it's as I say, blueprint. You add a blueprint, which is a lot of information that you can get lost in, and then you say in that map there are certain points that if you extract it clinically, you can deduct data and say, okay, this person needs, yes, exercise, but no matter how much they eat better, they change their gut GI symptoms and affect your neurons, they still might have a deficiency that they could benefit from medication. And this comes to play for people that don't like taking any medications. They don't like it. They are suspicious, right? These days, people after COVID, I think a lot of people question medications, right? Vaccinations and so forth.
Absolutely.
So you have to have some data, solid data to say, you know what, you've done your best. Your gut's working fine now. We worked on your gut. We worked on your health. You're exercising. Your nutrition is good. This is the reason that you're not responding.
I can imagine how hard it is to be able to sift through, because like there is the data drive, making sure that the data is there to ensure that this is the right path for, let's say, X drug. But then you have all these other different influencers that are out there that might be promoting or pushing some other, whether it's agenda or, I mean, I hear this pretty common where it's like, oh, I'm just going to let my body heal itself and do what it needs to do then. Right?
Well, we hear that all the time.
Really? Mm.
You want to do that in a smart way though, right? So, you want to, with the example of the gut is interacting with all parts of the body, the brain, hormones, neurotransmitters.
It's the biggest organ to produce
and
certain hormones.
Coming soon is a lot of knowledge about how the microbiome impacts that. We have the anecdotal stuff that you do microbiota transplants from a heavy person into a thin person and the person becomes thin. Those are all well documented. But I think with the advancement of AI and the ability to look at enormous data sets and make sense out of them, there's going to be a whole lot there. But again, you want the data to know, what to do about what might be deranged, so to speak, that manifest in these different symptoms.
Yeah, the more palpable things that, if, some people still, psychiatry is a field that, some people feel very passionate about, they're against medicines, right? And I understand it. But more palpable things that people can understand is this, like if I have a patient that has a mutation that cannot handle certain medicines, not handle, I use the wrong word, cannot metabolize it like other people. And this patient needed to get a procedure. In that procedure, after the procedure, they need to be on certain blood thinners. As you said, average person would get a medication called Plavix. Before this person goes to get their procedure, then I said to the doctor, no, it will not apply to my patient. This specific patient needs to get a different blood thinner because based on pharmacogenetic, actually, you did the whole genome sequencing for him. He needs to get a different medication. So these are the things we are referring to, that sometimes we are born differently and our genotype determines what we can do with that genotype or what we can't. If I'm born tall, I'm different, right? So I can do certain things and certain things are harder for me to do. So, but psychiatry is a tough field because you can't palpate it. It's hard to
it's not, sometimes it's not as
tangible.
Then, yeah. So as clinicians, then I am curious to know what are some of the patterns that most people miss. So like you mentioned, I mean, with AI, to be able to analyze all these different data sets, there's going to be so much information there. With all of that information there, I feel like there's also got to be some things that are missed when they're like most common. So like, for example, like we were talking, we looked at a case today, right? And there was a few things that were like, oh, like this wasn't in here, well, this wasn't there. And so I guess any common patterns that you see within data that you feel like clinicians should always look at?
Well, in the personalized precision medicine world, which we're living in now, you want as much information as you can gather to do careful risk assessments to know where you should put your energy. I think we were looking at a gene APC that is associated with certain colon cancer, and this particular patient completely unaware that they were carriers of that gene, and that completely changes how you would approach things like routine screening, like colonoscopies and whatnot. So you just need that information so the pattern, what's missed is things you could know that you don't know, but you could know. And it's not like, it is kind of rocket science, so it's high science, but it's not like it is, unimaginable that we would know these things. It's as simple as doing whole genome sequencing and careful analysis. Talking about pharmacogenetics, everybody should have pharmacogenetic profiling. It costs people their lives. A lot of babies die because they haven't had pharmacogenetic testing. I say alive was more common back in the good old days. They would get codeine that was rapidly metabolized to morphine, and they would basically go into respiratory failure. I mean, that can be known ahead of time.
I was just reading over an article, the new medications that are used, GLP-1 agonist, Mounjaro, Wegovy, and Ozempic. Some people have gastroparesis. Now, most people are okay. Now, you've heard data that some people get autoimmune or gastroparesis. The intestines basically doesn't work. They lose peristalsis, right? They lose that peristalsis. There are tests that can be done that I think in the near future, you can assess the risk of patients developing these sort of gastroparesis. It's MC4R. I mean, there are so many different genetic.
The beauty is once you've done whole genome sequencing and
then you
so on,
that.
And I mean, it's not thousands or tens of thousands of dollars, it's hundreds of dollars to do a whole genome sequence. You don't have to fly blind. You can know these things ahead of time and have that to take care of. It's just going to be coming.
So I think it's going to be even better in the next few years with advance of AI. So the key is this. The key is not just having the information. The key is to have great clinical information to feed data and collect the things that are generally missed, right? Let's say if you're starting a new medication, right? If you don't have pharmacogenetic, the patients could have hypersensitivity reactions. Some patients can have hyperbilirubinemia and go to hemolysis. And currently, there's certain very limited number of drugs that we use that physicians do genetic testing.
Right.
But it's surprising with the most people at certain age take one or two medicines at least, right?
Yeah.
And let's say SSRI. A lot of people are on SSRIs for depression. And if you do pharmacogenetic, you'll see right away this class of medicine is not good for the patient. You wouldn't even start it.
And I saw something, a company recently that does the HLA-B57 typing, which can be highly predictive of this really awful reaction to medications called Stevens-Johnson syndrome. So in the future, and the future will come very, very quickly because the technology is there, and
It's easy.
It'll
be
it's
easy and less
it's cheap
expensive.
and easy, and there'll be an immediate benefit of not having people endure something like that, which is a hundreds and hundreds of thousands of dollars hospitalization for someone
At
with
least.
Stevens-Johnson.
For example, statins. There is a gene that you can check to see if patients develop myopathy, and it's quite common. You see that with patients. So the problem is, again, traditional medicine in med school doesn't emphasize these pathways, and when you go to a doctor, they don't have the time slots, 15-20 minutes per patient, in and out. I have a cold, they come get a medicine and they go. They don't have time to critically think and say, this is the 5th time this patient's come in for a cold, there must be something else going on, right? So 1 is time, 2 is that patients are going in and out of the offices. 2 is broadening up and teaching med students that there's other pathways that they need to learn. And, schools need to teach them.
I know. And it's amazing how little, even to this day,
Yes.
that they're moving in that direction. It's just totally locked into the status quo. Medicine is a field ripe for disruption, and disruption's coming whether the field wants it or not.
Yeah, I mean, and as difficult as is as a physician, because there is not a day that I don't get a question of, I saw this on Instagram, I saw this in Google, I saw this in this platform. I think it's hard for a physician because we constantly have to say, thank you, but no, this doesn't apply to you, or let me check into it and I'll get back to you because I don't know everything, right? I don't know all these genes. It's impossible to know all of that, but it's pushing medicine and it's pushing physicians to search more. And I think with more demand, there will be more innovation and product and changes.
Yeah, and it's going to come more than likely from the grassroots up. But I think really patients are going to be asking for this from doctors like yourself. And once doctors are wanting this, then I guess the payers may or may not start paying. But especially in a direct patient care, which is what we call when patients pay us cash rather than go through the sick care insurance reimbursement episode for when something bad happens. The patients are going to demand that. Doctors are going to steer in that direction.
But insurance companies better help.
So I was at a talk once, and a United Healthcare CEO, not the guy, unfortunately, that died, but his boss was talking at an Illumina conference, and someone asked him, what is it that makes a insurance company decide they're going to pay for something? And so everyone's out there in the audience. There's probably 500 or 600 people because Obama and Bill Gates were talking the same day at the same time. And everyone's going, gosh, so someone raises their hand and says, oh, if it's a proven benefit. Guy goes, nope. That's not what makes us pay for something. You'll save money down the road. Nope, that's not what makes us pay for something. You know what makes them pay for something? It's claims. When doctors file claims to have a certain procedure or a medication or whatever, market forces require them to pay for it. So they follow market forces. That's what makes them decide what they're going to pay for. And that market moves in response to what doctors ask for their patients.
Yes. So that's very important. I think that's one advantage of internet. Advantage and disadvantage, as I explained before. It will shift the market. It's going to take some time, but it's not. But I think, as you've noticed, because of internet, the data is passed around a lot faster than 10 years ago. Kids are even aware of certain things that they weren't aware. Right? Our kids are more aware than...
They're growing up fast these days.
Yes. So I'm hoping that insurance companies, pharmaceutical companies, and politicians are able to move with rapidly developing science.
That's not going to happen, though. I mean, it's not. And so the question is what is going to happen? And I don't know. So let's just say we have a crystal ball and we know that, common sense is not going to prevail per se. So then what?
It's a complex question, and I don't know if I have the answer for it, but I really do think it's going to at least shift the needle for some improvement. I'm not expecting a miracle.
I think what might happen and might be helpful is that more of the dollars spent on healthcare are chosen by the patient, rather than have the system dictate to them what the dollars get spent on and not spent on. At some point, I think patients are going to be able to take more control of their, with these health HSAs, FSAs, high deductible insurance, where the patient themselves start making decisions about what they spend their money on, and probably, following the advice of their doctor or
I hope so. My concern is, as HMOs are getting bigger and bigger, the control over what patients can do, what's offered to patients, are going to get worse. And
that's clearly not the answer, and that's big movement in the wrong direction.
Yes. So
I think that's going to get disrupted, though.
I hope so.
I really think, and
they're going to come after me.
Yeah.
No, but that's what worries me. It's because these companies and organizations are getting bigger and bigger. As you get bigger, there's less personalization and profits come first. So I hope maybe consumers need to unite more somehow.
I saw a post from the founder of MIDI. Are you familiar with MIDI? It's a women's health, telehealth thing. Anyway, her quote on LinkedIn was, and I'm not going to get it exactly, but the gist is, it's not really the people that are going to advance personalized precision medicine are not entities that make their living by denying care. Mm-hmm. That's just not going to happen.
That's true.
And yet we know that this is how medicine will be practiced in the future. And so then how is that going to, how's that serpentine course going to turn out?
Right, because you don't want this care to be provided. The care that is available and exists, the science, to be available to only a certain percentage of population can afford it, right? That's the whole ethical issue or question that we're dealing with. You want it to be provided for all. How do you make that happen?
I think how you do that is the patients just have to have more control over how the healthcare dollar is spent, and they'll move it. The question is, how do you get from where they have no control to some control? I think it'll happen.
You ever have patients scared of knowing more?
That's a good question. I think, yes, many patients avoid doctors or going to a doctor because they're scared of knowing more. How do you address that? It's very difficult. It's very difficult. And I think those are people that need more personalized care, because that's where you need to figure out why they're scared of knowing more and how to get them to come in. And those are the ones that you don't want to offer a test that it will cause more chaos. You want something, an actionable item that shows that you can, if you come in and do viral ultrasound, or based on your genes, you can do this and this and prevent it, let's say yearly or every 6 months, prevent something from happening. So you don't have to treat the disease, or you treat it very early on. It's not metastasized or it's not.
Exactly. And and virtually everything is actionable. Virtually, tell me something that's not, well, maybe if you have a glioblastoma multiforme or something.
Even that, you're having better treatments now.
Even that you would want to know sooner than later. So, what I find is that you just build that argument that virtually any information you get is going to help you in the end, and help you right away, that everything nearly everything is actionable. I have a hard time coming up with something that's not actionable. Someone says, "Oh, I wouldn't want to know if I have the ApoE4 allele." Well, of course you would want to know, because even up to a year or two, I mean, for the last couple of years, there are treatments that, you could get, and there's more coming down the road. Mm-hmm. But of course you would want to know, because there's so many things you can do with your lifestyle with a holistic approach, getting your sleep right, reducing inflammation, exercise, diet, all that stuff. It's very well established that people that do well on those things have the lowest incidence of those diseases, even despite their genetics. So if you had a genetic tendency towards something, or, your family history and your current labs and your biochemistry and imaging is pointing in a certain direction, you would want to know, because it's actionable.
It will be a motivation for you to live a certain life, or remove yourself from a certain lifestyle.
It is kind of wild to think, though, because, there's this data that, of course, is going to help, but then there's also the skepticism that is going to be used against them, too.
Oh, yeah.
Like with employers or insurance companies not going to be, or their premiums are going to go way higher because they know a certain thing.
Yeah. So, that's why this emerging field, what Biography Health, we really lean into privacy and security of the information, patient ownership and control, high integrity of the science, et cetera, but that's because of those kinds of things. And there are laws that, protect you. GINA, the Genetic Information Non-Discrimination Act. Oh, I remember that. IE4 must not be kicking in yet.
You have time.
That prohibit discrimination with employers or obtaining health care. But you know what it doesn't cover? It is covered at the state level in California, but things like access to life insurance and long-term care insurance, those people can still ask for that information, and you're required to give it if you have it. So the legislation and the ethics is going to be slow to catch up.
Yeah, that's why I think policy shifts are important. So one problem is scientists and physicians generally not politicians.
Nor good communicators,
yes.
On a public stage.
Yes. So there is a disconnect, and that's why we don't have a lot of power in politics, because we're just not administrators. We're not, it's a difference. So that's where public won't get the benefits of physicians being very active in politics. Because bottom line is, that's what needs to change before we can change what insurance company pays, right? I have the tool. However, I would need to be implemented if the patient can afford it.
So closing out the show, Dr. Monsef, if there is a female immigrant, physician, entrepreneur that's listening to the show, what advice would you give them as they're, let's say, starting out their career?
I think first generation immigrant, automatically, most of them are hard workers. Just when you have to survive, or they say necessity is the mother of all inventions, right? So when they come in and they're just learning and they have to work hard to get things done, they're already a step ahead of certain other group that want to start their own business, so they shouldn't worry about, oh, I don't speak the language so well, or I can't do this like in American or native so well. I think you just need to throw yourself and be yourself and be true to yourself and think about patients. And I think patients will come.
I love that. And if anybody wants to reach out to you, whether they're a patient or physician, entrepreneur that wants to learn from you or connect with you at Ascending Medicine, what's the best way that they can reach you?
I think the best way is to reach us through our email, which is info@ascendingmedicine.com.
And that'll be in the show notes too.
Yes.
Well, Dr. Monsef, thank you so much.
Thank you for having me.
Coming on to the show.
So much.
We're going to have you back for another episode.
Thanks for joining us on the Precision Medicine Made Simple podcast. If this episode inspired you to learn more about your health, please leave us a review and share the podcast with a friend. Your feedback helps spread the word about the power of precision medicine. Remember, taking action today can lead to a healthier tomorrow. See you next time.